So first of all, we'd like to thank you for the invitation to give this seminar. I think that as representatives of the Trisomy 21 Research Society, one of our goals is specifically to share the information, the scientific information, with the society in general and with Down syndrome associations. Professor Strydom is the president from Trisomy 21 Research Society. I am the past president, and both of us are also contributing to different committees and so on. So we are here on behalf of the Trisomy 21 Research Society COVID-19 initiative. And the challenge, as you know, when the pandemic started, we were worried that people with Down syndrome may have additional health issues that might increase the risk for more severe COVID-19. So we were concerned about the possibility that people with Down syndrome could be more vulnerable. And the reasons are these comorbidities that are also comorbidities or health issues that increase the risk for more severe COVID-19, but also that viral infections and pneumonias are an important health concern for people with Down syndrome. And this is probably because they have different immune responses that may put them at higher risk for infection. So this was the ground of our decision. Oops. Here. And also the other reason was that when hospitalized, in fact, people with Down syndrome have greater risk for admission to a hospital due to infections. And when hospitalized, they have more prolonged stays at the hospital, and they may require intensive care support. So why did we start with this project? Because as I said, we are members of the Trisomy 21 Research Society. Let me explain you a little bit who we are. So the Trisomy 21 Research Society, T21RS, is the first international nonprofit scientific organization that was founded to promote basic and applied, so clinical and basic research on Down syndrome. So our aims are to stimulate the translation of all the research that is being done to be able to apply new scientific knowledge to improve the quality of life with people, for people with Down syndrome. And we have basic and clinical research, but what is very unique from our society is that we make this link with Down syndrome associations. We try to support them in their decisions. We try to provide scientific advice, etc. So this is one of the reasons we are very strongly and very fruitfully, I would say, collaborating with EDSA. In fact, EDSA is part of some of our scientific projects. So this is a really fruitful collaboration that we are having. And let me just explain very briefly that you can find us at this website. We're also on Twitter, and you can become a member. Even if you are a family, you can become what we call an associate member. And this will provide you also with access to different informations and access to different activities. And in fact, one of the activities that I'd like to highlight is the virtual conference that will be held next year. And specifically, we will have a science and society related or neighboring conference. So we will keep you informed so that you can attend and learn about the more important activities and research findings. So how about the COVID-19 initiative? This was started in March last year. So no, this year, sorry, 2020. And the idea was to create a work group that, as you see, is very international, to start some research activities related to COVID-19. So we wanted to really understand what was going on, what was happening with the Down syndrome population in the COVID-19 situation, right? In the context of the pandemics. And the main activity was to create this survey that we are today discussing and presenting. But of course, T21RS has made a lot of other actions. So we're very much in contact with stakeholders, among which EDSA is one of these stakeholders, and family associations and Down syndrome foundations and associations. So we initially made some recommendations to protect individuals with Down syndrome. We also did prepared and launched this online survey, and Andre Strydom will present you some of these results. And we have been very much involved in, for example, making some statements about the shielding of individuals with Down syndrome during the COVID-19 pandemic, based on what we found in the survey, right? And also, again, the same, we made some statements with regard to vaccination. So we're trying to really be helping and promoting that scientific knowledge is then applied to specific measures, right? And besides that, we have been making a lot of local and international activities, webinars. These are just some examples. And there are 6 publications ongoing. So there are 2 reviews in which we have reviewed all the knowledge that is there about Down syndrome and respiratory infections, immune system, etc. There are 3 original papers that are ongoing. One has been already submitted, that is the results of the international survey. The other is the pediatric population results that we'd like to give special attention also. And then there is another paper from the Spanish task force that is comparing respiratory infections, non-COVID respiratory infections with COVID-19 cases in Spain. Besides that, we have one meta-analysis that I will briefly present, and also Lancet Neurology correspondence. So we have been really trying to make this happen. So sorry about that. Okay, so let me explain you first what was our first approach from Trisomy 21 Research Society. So the first thing that we wanted to understand was to what extent, besides what was already known about the different immune response and so on, what was there from the biological point of view, right? So to this aim, what we did was we took all the studies that were published on the different changes, genetic changes in Down syndrome, and we were comparing those with the genes that are changing when SARS coronavirus 2 is infecting a person, right? So to see what was the overlap, what were the common factors. And to make a very long story short, I have tried to, I hope it will work, prepare a video. So before, when we were training, it suddenly didn't work. Nothing was working in my computer. I hope it will not happen again, but if it does, just let me make a brief statement that this, what we found is that there are both protective and vulnerability factors in Down syndrome. And this existence of both factors is what may explain what Andre will explain you later, okay? So let's hope it will work. But if not, I disclaim already. Okay, good, it works. So I have prepared a little video. This is meant to be the coronavirus, right? So you see they have this structure. They are, of course, very contagious, but they have these little proteins that you see in the surface. These are called the spike proteins. And what happens in Down syndrome is that the entrance of the virus is somehow favored because some proteins that are needed to favor the entrance of the virus are overexpressed. We have 3 copies of those, right? So when the virus enters, it hijacks the protein making system of the cell to make the viral proteins, right? And this kind of is partly more difficult in Down syndrome because the viral replication, there are some factors that reduce viral replication. When the virus replicates, it kills the cells, right? So they use the cells for replicating, for making more viruses, but then they kill the cells. But then the other part is how we respond to it. And the problem is that in Down syndrome, we have increased inflammation, right? So what happens is that the fluid accumulates in the pulmonary areas, and these may lead to more severe outcomes, right? So basically, to make a long story short, the two factors that I would like to highlight is that there are some specific genes that are triplicated in Down syndrome that may help the entrance of the virus, right? Because they are collaborating with this entrance. The second thing that we have to highlight, and this was highlighted already in the beginning of the pandemic, is that we have a different inflammatory and immune response that may lead to an increased, let's say, cytokine storm, what has been called cytokine storm. That is what creates these more severe cases of COVID-19. So to make a very long story short, and I hope I did not take too much time from Dr. Strydom presentation, what we have seen in this theoretical study is that there are some protective, but also some, let's say, vulnerability factors in Down syndrome. So I would like now to give the floor to Professor Strydom, and I will stop sharing my screen so that he can share his screen because he will present the actual results that we have from these. This is the most extensive and more important survey done internationally on the impact of COVID-19 on Down syndrome. So, Andre, the floor is yours. Andre, you are muted. We cannot hear you. You are muted, unfortunately.
There you go. Can you hear me now?
Perfect.
Okay, I was just saying while I'm putting the slide up that thank you for this great introduction of the potential risk factors that may increase the risk for COVID-19 and its outcomes in individuals with Down syndrome. But as you mentioned, there may also be some protective factors. And if I've understood you correctly, Mara, you mentioned that replication of the virus may be less significant in people with Down syndrome. So that might be a sort of protective factor to keep in mind. Is that right? So what we wanted to do within the Trisomy 21 Society is next to see what is the actual risk in people with Down syndrome while the pandemic was ongoing. And so in order to do that, we designed a survey which was completed by either clinicians or families of people with Down syndrome. But in some cases, they could both complete information on the outcome and symptoms of COVID-19 infections in people with Down syndrome. So we asked them to report to us if people have been infected with the virus. And so what we did was we sent out a survey and had now more than 1,000 responses of individuals with Down syndrome who had been infected with COVID-19. And it's sort of split between clinicians and families that reported them. about half of those have been hospitalized, so actually had to go to a hospital because of the infection. And most of those, at least by the time the survey was completed, had recovered. And as a proportion of people have sadly died. So to understand whether people with Down syndrome are more at risk of poor outcome or otherwise present differently from people in the general population, we had to have a way of comparing what we find in our survey with data from the general population, from other people without Down syndrome. And so the main comparison that I will be presenting is a comparison of using data from a large UK survey of people hospitalized for COVID-19, nearly 60,000 people who have been hospitalized in the UK. We managed to get access to that data and identified that there was 100 people with Down syndrome within that data set. And so that meant that we could make a direct comparison and match people with Down syndrome by age and by sex to people from the general population. There you go. So the first thing that we looked at was symptoms of COVID-19. So when people with Down syndrome are infected with the virus, how do they present? And firstly, we noted that the common symptoms were similar to in the general population. So fever, coughing, shortness of breath, and then nasal symptoms. By that, we mean sort of a runny nose, which was common, particularly in children. And we also noted that it's shortness of breath, which indicates whether the person is more severely affected, because that determined whether somebody had to go to hospital. And so an interesting question is whether symptoms are different in people with Down syndrome compared to other people from the general population. And here we based now solely on hospitalized patients, because that's where we could make that comparison. And so at admission to hospital, we saw that, as already mentioned, fever, cough, shortness of breath are common. What is different in people with Down syndrome, more common in people with Down syndrome, are the altered consciousness, so confusion, being not sure, not as responsive as they normally are. Usually that suggests that people might be more severely ill by the time they get to hospital. And then there were other symptoms that were less common in people with Down syndrome, so including joint pain or muscle aches, so pain in general, and also feeling nauseous. We think that some of this may be explained by the fact that people with Down syndrome may not be able to report some of these symptoms, or otherwise our clinicians are not necessarily good at asking them or understanding how they might be presenting, but largely fairly similar. And so next, what we did was to look at what existing health conditions may increase the risk for poor outcome of COVID-19 in people with Down syndrome. So here we knew already that many people with Down syndrome may have additional health concerns. And the question is whether those health concerns may affect people and may mean that they present with a more severe form of the illness. And so what we found was that some of the risk factors for severe outcome of disease among patients with COVID-19 with Down syndrome were age, older age, just like in the general population, obesity. We knew already from general population data that this is a risk factor. But in people with Down syndrome, it was quite prominent. We found that dementia or Alzheimer's disease may also mean that people are more severely affected. And just like in the general population, males were more severely infected. And for hospitalization, but not for mortality or death, individuals with a history of congenital heart defects were more likely to go into a hospital. And then factors that was not associated with increased risk of hospitalization or death were where people lived. So it didn't matter whether they were living with family or in a residential facility. It didn't matter how severely they were affected in terms of the learning difficulties, or whether they had thyroid disorder, or whether they had additional mental health issues or behavioral problems such as autism. And then things that looked like it might be important, but we did not reach statistical significance, were factors such as gastroesophageal reflux, seizures, particularly in children. In children, seizures or a history of epilepsy seem to be associated with higher risk for going into hospital, but not for higher risk for mortality, and obstructive sleep apnea, as well as lung disease. So most of these things actually increase the risk for lung problems through aspiration or inhaling fluid into their lungs, which then make them more at risk for a severe outcome of COVID-19. So then we looked at what happens when people with Down syndrome are admitted to a hospital with COVID-19. So what we saw was, in comparison with people from the general population, that people with Down syndrome were more commonly affected by complications of the lung, so had more severe lung infections. So the virus caused a more severe pneumonia and could then lead to a secondary bacterial infection. And people with Down syndrome are also more likely to develop an acute respiratory syndrome, which just means that their lungs are really struggling to cope with the infection. Complications that were as common in patients with Down syndrome as in the general population were heart complications, so heart failure, for example, kidney problems, and blood problems, anemia. And then we looked at whether people with Down syndrome are more at risk of dying after developing COVID-19. And again, we're focusing on people who have been admitted to hospital here. So first of all, if you were just to look at rates, crude rates in individuals with Down syndrome compared to the general population, and this is data from big hospital surveys in the UK, in New York City, and in Spain, it looked like it was fairly similar, particularly in males, say, and in females. What we saw was the pattern that males were more likely to be severely affected. So overall, the proportion of people who died after being admitted to hospital was about 1 in 3 in the general population, but also in people with Down syndrome. However, when we tried to dig into that in a little bit more detail and looked at age, the risk associated with age, what we saw was that people with Down syndrome are younger when they die with COVID-19 than the general population. And if we matched people with Down syndrome or controlled for age compared to the general population, and then you could quite clearly see here in red that after age of 20 into the age of 30s, and particularly after age 40, the risk of dying was much higher in people with Down syndrome compared to the general population. So there you could see that. Whereas people in the general population were at much higher risk after the age of 70. But we of course know that many people with Down syndrome don't live into their 70s and 80s. And so the risk for death due to COVID-19 was shifted, as it were, to a much younger, several decades earlier. And so we estimated that the risk for mortality or death in a person with Down syndrome is similar in those over the age of 40 to those over the age of 80 in the general population. So we already know from newspaper reports and so on, and other reports that it's elderly people that are most at risk. But I think in people with Down syndrome, we could say that the risk is very much increased after the age of 40. The good news is that in our survey, we only found a very small number of children with Down syndrome who have died due to COVID-19, only 4 in the entire survey so far, 4 out of 1,000 individuals with Down syndrome. And so it looks like the risk, just like in the general population in children, for more severe disease is much less than for adults with Down syndrome. So that is at least some good news. The other thing to mention is that the children in our survey that have died were all living in developing countries, if you want, or countries with less universal healthcare, such as in India or Brazil. So, in summary, the take-home messages so far from the analysis that we have done is that in order to monitor for infections, you should look out for the same symptoms in people with Down syndrome as in the general population. So fever, cough, shortness of breath. Increasing shortness of breath and change in consciousness or confusion may be a sign of worse illness. So shortness of breath or becoming a bit confused or sleepy, as it were, may be a sign of worse illness if they have COVID-19. When people are hospitalized with COVID-19, people with Down syndrome, then lung complications are more frequent. And that's something that clinicians should be aware of when they look after people with Down syndrome with COVID-19 in hospitals. And comparing people with the same age, gender, and ethnicity, adults with Down syndrome age 40 years and older have a greater risk of death compared to patients without Down syndrome. And their risk is really the same as in the general population of older adults over the age of 80. Only a few children with Down syndrome have died of COVID-19. I've already mentioned that they were living in countries with limited healthcare provision or had additional health needs. And so this work has led to us making recommendations about prioritizing vaccination for people with Down syndrome, particularly adults with Down syndrome. So, for example, in the UK, they're rolling out vaccination for COVID-19, firstly in older adults over the age of 80. And what we're trying to tell the government is that they should include people with Down syndrome now already in the first stages of the vaccination program if they are over age 40, because the risk is the same. So just to be clear, what we haven't been able to do so far is we're not able to say whether people with Down syndrome are more likely to catch the virus that causes COVID-19, although Mara's work has shown that it might be a possibility. But we also know that many people have been good at keeping themselves safe. So many people with Down syndrome have been very good at wearing masks or washing hands and complying with the general kind of rules to keep themselves safe. We were also not able to say how many people are asymptomatic, in other words, can have COVID-19 without showing symptoms when they are infected with the virus. But we have identified a few people in our survey who's tested positive but didn't really show signs of disease, so it is possible. And then finally, we don't yet know how best to treat people with COVID-19 if they have Down syndrome. At the moment, the best we can say is that they should follow the same sort of treatment guidelines as in the general population, but should monitor more actively for lung complications, such as secondary lung infections. I'm not going to talk much about the limitations of the work, but just need to sort of keep this in mind. Of course, like all surveys, there's going to be some limitations. You can read through this yourself. One of the main things are that we've collected data from different countries and different healthcare systems, which is good, but on the other hand, it may make it slightly more difficult to extrapolate from our data to a specific country. And it may also be that we haven't included, of course, all of the COVID-19 cases with Down syndrome. But nevertheless, it was a very big survey and a big effort from everybody involved. So I think that's the last slide. I'm going to finish there. And I think there might be time for some questions.
Yes, thanks a lot, Andre and Mara. We have several questions, and Mara already started to answers. Maybe we could start with first question from the word from Belgium. And please, Mara, could you just what you wrote maybe to say as well to all of us?
So what was asking if, I mean, I don't find the question now, but...
Yeah. How can you test if the test person is more vulnerable and possibility could overreact to the this test mRNA vaccine immune, and could this reaction be different from the wild type infections?
Yeah. So basically, what I just wanted to mention is, of course, there are new technologies that are being applied to COVID-19, right? That were not so kind of used before. And one of these is these mRNA vaccines. But what your immune system react to defend from the virus, right? And the way of doing this is letting your body, this way you can kind of hijack your own body system to create proteins that I showed you in the video, right? To produce these viral proteins, and specifically this spike protein I was talking about, so that the immune system recognizes it and can then attack the virus when it infects you, right? So this is the idea. I mean, this has been, even though, yeah, of course, it's quite new, but it has already been kind of tried in humans for other infectious diseases. And I mentioned Zika virus and cytomegalovirus and rabies virus as some examples, right? So, of course, we may have some adverse effects, as has been shown for some of these vaccines, for how the virus is the mRNA is administered. So, but in fact, I don't see any reason why they could overreact to these vaccines, right? The other question that we may put on the table is if the vaccine will boost sufficiently the immune response, right? But as for the overreaction, I cannot see why they should overreact, okay? I don't know, maybe Andre, you want to add something?
No, I think you've explained it well. I think that there has been some evidence in the reviews that we've done that that people with Down syndrome may not have the same antibody response. In other words, less of a response, may actually require booster immunizations.
Yeah.
So that's more of a risk than an overreaction, I think, to the immunizations. And though it may be good to to think about sort of monitoring the antibody response to the immunization to see whether the person needs a booster or not.
Yeah, and in fact, there are already some studies, and we are participating in one, to use these boosters and see how the innate immune response is building up. We are doing it in mouse models, but we are already testing how these boosters might be effective in increasing innate immune response.
Yes, we have some more question about vaccine. Marina from Croatia asked which one it will be the best to use of this vaccination, which one will be the best to use for our children or our person with Down syndrome. If I understand, you proposed that and recommended that vaccination for our children, it's okay from your side, what you suggest us, but which one it's good? Like example, you said this new one method, and also Oxford vaccination has something else. which one you would like to suggest to us, like families?
Oh gosh, I think that's a very difficult question.
Yes.
I'm not sure about the answer. Mara, do you know?
In fact, but I mean, you have to think that all these vaccines have been developed very, very quickly, very fast, right? But the process of authorization is very careful. And the European Agency for Drugs and also the UK are very careful in not approving anything that may be harmful, right? The thing is about the effectiveness. And in this sense, the phase 3 studies show a very, I think, a very promising and very high level of immunization. So my take on this is that we still don't know which would be better. We still need to see how the general population reacts. And I think that there is no initial biological factor that makes one or another better for Down syndrome people, right? So people with Down syndrome, yes, they have a worse, let's say, response in terms of immunization, immune response to these vaccines, not just to the COVID-19, we don't know yet, but to influenza virus, whatever, right? So this is something that has already been shown. So maybe they will need more doses, or we still don't know. But this is an effort that, for example, people in the Spanish task force are already taken, including people with Down syndrome, in clinical trials of the vaccines. And specifically, we are testing the Johnson & Johnson, the Janssen's in Europe vaccine, and the Pfizer also. So this is being done in hospitals in Spain, and I think it's the same in other countries maybe, and I can elaborate a bit more on that. But in Spain, people from, members from the Down syndrome, the T21RS, the Trisomy 21 Research Society COVID-19 Task Force, are already boosting that people with Down syndrome enter this clinical trial, so that we can have a bit more information and a more comprehensive study of their immune response. I don't know if I answered, because I start talking about many things.
Yes, it's so many questions about vaccination and which type, and maybe you could little bit look as well together with me, but it's mostly a question about vaccination. I don't know, could we cover all this question on the correct way? But I would like just to make some comment and ask you, does Monica from Germany ask about, are diabetes type 1 potential and the Down syndrome potential risk factors? And as well, do we have any research about conjunctivitis? Like a symptom for COVID with Down syndrome.
Oh, so the first question is about type 1 diabetes, whether that's a potential risk factor. I think what we should just be a little bit cautious. I should explain that it's difficult to analyze relatively rare comorbidities and its risk for COVID-19 outcomes in our survey, even though we have 1,000 people, data on 1,000 people. But we've had to focus on the more common health concerns, and type 1 diabetes, although it's more common in people with Down syndrome, is still relatively rare. And so it was difficult to see whether it is a risk for poorer outcome in people with Down syndrome. But we know from the general population data that it might be. So we're not sure, I suppose, is the answer to that. And then what was the other issue? Somebody else, I think Jacqueline asked whether some people with Down syndrome who recovered from hospitalization, are they more at risk for developing diabetes subsequently? Again, this may be something that's a concern in the general population. The answer to that is we don't know. But for our next surveys, what we will do is we are going to try and look at two things. One is we're going to try and monitor the response to vaccination, whether people have similar sort of response, or whether they have side effects or something like that. So during the next phase of the survey, we'll do that. But we may also include questions about subsequent problems after people recover. Because there are, in the general population, of course, some people who are reporting long COVID symptoms or symptoms last longer. So that is something that we still don't know whether that's a concern in regards to our community.
I think there is also a related question that is from Canada. Oksana, right, is asking whether, since there is no research on mRNA vaccines and Down syndrome, if it would be reasonable to look to other populations first. So what I can say in these is that first, I think there is a risk-benefit balance, right? So I think we need to protect people with Down syndrome. And in this sense, our take is that people that are going to be vaccinated, included in the phase 3 or phase 4 clinical trials, will be monitored very carefully to see how they react to these vaccines. Besides, in my lab, we are also doing a study, we are performing a study in some Down syndrome mouse models to see if there is any difference between the mouse models that have this partial trisomy and the euploid mouse models, I mean the euploid litter mates, so that we can at least have some preclinical data to support if first, if they really get immunized in the same way, and also how they would react to different types of vaccines. So this is something that is ongoing already, but of course it takes a bit of time. But in the meantime, I think that, you know, all the agencies are really very careful to not approve something that may be harmful or not effective. So I think my take is that we have to trust them. And of course, the data are based on general population, but if something, it could be less effective, but not more harmful. There are not at least theoretical reasons for that, right? Yeah. So I think the best response is to see how they react to the vaccine in these clinical studies that are very well controlled. Everything is really carefully followed, and this is our opportunity to know. And I think, to me, I don't know, Andre, you can comment also, but this
I agree with that. I think that at this stage, the benefit to vaccination would outweigh any kind of risk, because we know there's an increased risk after developing COVID-19 in people with Down syndrome for a poor outcome, and so it makes sense to prioritize them for vaccination. But we can monitor as things go on to see how, you know, whether there is an increased risk for side effects. I doubt it. As Mara mentioned, it's more likely that the response won't be, the antibody response won't be as effective in people with Down than in other people, and that they may in fact need a booster vaccination. And that's based on what we know about the pneumococcal vaccination, for example, in people with Down syndrome.
Yeah. I'm sorry.
Dinka, I was just going to say there's another question about pneumonia and influenza vaccines, so pneumococcal and influenza. Yes. And so I think that, I mean, part of the recommendations we made in Trisomy 21 Research Society was that this winter, certainly one should look into having an influenza vaccination and potentially also pneumococcal vaccination. In some countries, it's standard to offer pneumococcal vaccinations to people with Down syndrome. Others, it isn't. In the UK, it isn't. It's only for small children, but not for adults. And we think there might be benefit. We're not sure, but we think there might be benefit in offering that as well. Something to bear in mind, of course, is you can't have one vaccination after the other, so they need to be spaced out. So you would have to think and talk with your doctors about when to have which vaccination and which one to have first.
Yeah, but it's one question as well. Are this vaccination for the children or just only for the adults? Are there also for the children? Because, you know, in some countries they started with adults over some ages first vaccination. Yeah. What is the situation with our children with Down syndrome?
Yes, I think at the moment it's a question of prioritization. So one would have to start with people who have the highest risk. And so in people with Down syndrome, I would say that's individuals over the age of 40, and then move down. You know, I think ultimately it may make sense for everybody to have COVID-19 vaccination, even children, because of the potential for lung complications and hospitalization, if not mortality. But you have to start somewhere, right? And so it makes sense.
If I may add to that impact, in our survey, we didn't see that children or younger adults are kind of high-risk populations. But of course, this doesn't mean that they don't need to be vaccinated, as Andrea was saying, right? The only thing is that, of course, as in the general population, probably the governments will prioritize elderly because those are the more at high risk populations. But yeah, I think the way to go is to think about everyone for vaccination.
Yeah, and one question it is, are you going to monitor and record results from that vaccination and some reaction of the person with Down syndrome? Are you planning to make some research about that as well?
Yes, yeah, I mentioned that we are hoping to do that. So do a similar survey just to help to monitor the you know, the effect of vaccination program.
Andre, please, could you maybe look just comments from the Get the Graph? Yeah. Get the Graph. Maybe, Mara, you saw already that about, is that correct that we were 100 people with Down syndrome in hospital for COVID in 58,916 people without, so that would be 17 per 10,000. Population prevalence of the DS in UK is around 6.4 per 10,000 inhabitants. So do they have an almost 3 times larger chance to be hospitalized?
Well, I think, yeah, I think it's it makes sense to think that people with Down syndrome might be more at risk. One might be more likely to be hospitalized if they develop COVID-19 because of a more severe, slightly more severe course of disease, particularly in the 40. But whether we could say that it's definitely 3 times more, it's difficult to say from that data. We haven't done a statistical analysis to check that, and it may be better to use different data sets where you have more population coverage, not just hospital data. And so in the UK, for example, we are looking into using the primary care data sets to answer that kind of question.
Yeah, and also there are differences in terms of, you know, this is an international survey. So as for the hospitalizations, there might be country specificities that may bias the data. So yeah, I mean, it depends on which country you are. The rates of hospitalization might be different.
Exactly, yeah.
So I think there is also a question about conjunctivitis. I don't know if you did kind of answer this, Andre.
No, I can't remember. So it's a question about whether conjunctivitis might be a sign of COVID-19. Right?
Yeah, in fact, it has been proposed, but yeah, it's, you know, the problem with COVID-19 is that there are still a lot of open questions. And we, in fact, are building up on new knowledge to adjust our survey. So conjunctivitis was in fact not asked in the first round, but is now asked in the second round. So we're trying to adapt the survey to the new knowledge that is coming out. Yeah, certainly this could be one sign, but to what extent it is specific or not, or it could be an alarm sign of COVID-19. I mean, I would go for the safe side, and if you have a person with Down syndrome with conjunctivitis, I would take, if there is also other symptoms, I take them to be revised by the medical doctor.
Yeah, Mara, do you see some more comments what we didn't answer until now? Okay, this last one from Marina from Croatia. If you see, apart from vaccination for COVID, are there any pharmacovigilant drugs side effects follow-up specific for this? It would be interesting for many medicines to have evidence-based information for prevalence. Do you know any of research ongoing or institution following that?
Not specifically, no. So it's a good suggestion to think about pharmacovigilance in general in vulnerable populations, such as in people with Down syndrome, but I'm not aware of any specific work in that area. We have looked, for example, at side effects of psychiatric drugs, particularly antipsychotic drugs, at primary care level, comparing people with intellectual disability, including people with Down syndrome, but not exclusively people with Down syndrome, with general population, and have noted that there is some higher risk for side effects. In this case, it was particularly movement side effects, neurological side effects. And so in general, we believe that people with intellectual disabilities, including people with Down syndrome, may be at a higher risk for some kind of side effects. And so as a principle, what we normally do is to try and start with lower doses. So we might start with the doses that elderly care physicians would use to be careful and safe, and then increase the dose slowly as well, to be sure that we don't have problems, and monitor for the problems as well. Whether that applies to vaccination programs, that's a different issue, I think. But certainly for medications such as tablets, we tend to be more careful in people with Down syndrome.
Regarding also, if I may contribute a little more, regarding to other medications that are being used for COVID-19, of course, most of the experience is in general population, but as you know, there are already some drugs that have been not kind of supported for COVID-19. And in fact, one of the questions in our survey is about the possible drugs that persons with Down syndrome have received. Unfortunately, this is only answered in the clinicians' surveys, not in the family surveys, because families normally do not know about that. And this, of course, makes it a bit more difficult to have sound results on this part. But yeah, I mean, this is something that is also being taken into account. And I think we don't have data right now, but it's something that, as Andrea was saying, is, of course, a matter of, let's say, concern. And what I can say is that in some Spanish hospitals, they are recording all this data. so that we can at least have the information. And this is done by several hospitals here in Spain. So let's hope to have some answer in the next future.
Yeah, we have one question or two, even two questions. Do we see that celiac disease are also one of the risk factors for the COVID-19?
I think that's the same issue as with diabetes. So some conditions were just too rare for us to be sure, and so we were not able to analyze it. And celiac disease was one of those. So we can't be whether it's a risk factor or not.
Yeah.
But reflux was potentially an additional. I think that's because of the risk for aspiration and developing lung problems.
Yeah. What type?
Yeah. Sorry, Andrea was saying, our problem is that comorbidities that are not such prevalent in Down syndrome, of course, they are very difficult to catch up in our survey, right? So the problem is if there is a comorbidity that has, I don't remember exactly for celiac disease, but I think it's around 10 to 20%, something like that, in the studies that I remember by head. But of course, this is very difficult to catch in our survey, right? So hopefully as it increases, and here I'd like to invite you all, please, to report any case you have. You can contact us, just search for the Trisomy 21 Research Society COVID-19 initiative, and it would be extremely useful. For example, now in Spain, we have people with positive PCR, but without symptoms, right? So all these cases will help a lot to make a clear picture of what's going on. But we need you, guys. We need your collaboration. So please, please contact us and help us build up this initiative, because it's in your hands. In fact, if I may, most of the answers, you have them. You have them. If you contribute, we may be able to sort out the responses, right? So contribute.
Yeah. Okay, thanks a lot. Andrew, would you like to say something more as well? Because we are now 8 minutes past 6 o'clock p.m. And
before you end, Jacqueline asked to say something, and Jacqueline asked something, Mara, about protective factors. It's very important. What are the protective factors? Yeah, like a low virus replication.
Yeah.
Can you comment more?
So she wants to talk before, or?
No, she would like your comments about, can you comment more about that part?
Sure. So the thing is that, I mean, this is a theoretical study, right? But from this meta-analysis, I mean, we took into account all the transcriptional studies that have been made on Down syndrome. We took also into account all the studies that have been made on host response and on viral related proteins like ACE2, like these doorways into the cell, right? So, okay, if we summarize everything, we have viral entry is facilitated, but then we have some proteins that might be contributing to inhibition of viral genome release. So that when the virus enters the cell, it has to hijack the protein synthesis system of the cell to use it in its favor, right? So to replicate, right? So part of these processes are kind of less favored in Down syndrome because of some specific proteins. And I could mention them, IFMTM or other proteins, right? Then there is also some proteins that may be contributing to a decreased protein synthesis. So maybe you can make the virus enter more, but then it cannot replicate as effectively, and because of the proteins that it needs to create the capsid and these spike proteins that will allow it to enter other cells, those are not there, right? So basically, if you block it, if you block these processes, you may help to reduce this viral replication, right? Then there are some processes that may act in the other way around, like increased inflammation and increased, for example, bradykinin signaling that may lead to increased M2 macrophages activation. And this may lead, I mean, to not go into too many technicalities, would favor more severe cases, right? So the severity might be increased. So there is a balance, and probably we will see that there is also an individual response that might be different. So what we know from Down syndrome is that there is a kind of quite high individual variability. And if we look at this kind of broad range of different responses, even in the immune system, what we can see already is that there might be people with Down syndrome that might be protected and will get asymptomatic infections. And this is what we'd like also to catch up in our survey, right? But instead, there might be people, like in the general population, that when infected will develop more severe infections, okay? So, of course, being a theoretical study, it's kind of pointing the directions. Where should we look at when evaluating the responses of Down syndrome people? But it unfortunately doesn't give very kind of strong and straightforward responses. So I hope I somehow answered you.
Okay, we just have. Sorry, Julia.
Yeah, Jacqueline, I unmuted you. If you want, you can add.
Good answer.
Oh, Jacqueline, hello.
Yeah, it's a good answer because it's very important to understand also why in some families, when there is COVID and even very, very harmful COVID, some person with Down syndrome either were asymptomatic with, as you said, PCR positive, but no symptoms, and even they show the virus, they gave antibodies, they show antibodies, and it's some families. And it's very, very interesting. That's why I ask you, because of the replication, of maybe because also of the exit of the variants. That's very interesting.
Absolutely. Thank you very much for the question, Jacqueline. It's great to see you. Jacqueline is one very important Down syndrome researcher. So she's a scientist, but also a family of a person with Down syndrome. So thank you very much for your comment.
Thanks for Jacqueline and thanks to Mare. Do we have some more questions, or maybe we are going to close? On the Facebook, we didn't have at the moment any questions, but on the Facebook, we will have a completely record of this our webinars. As well, in a few days, we will send to all participant information where on the YouTube could find our recording webinar. Really, thanks a lot to Mara and to Andre. It was very, very nice. We are very pleased that you were today with us and have a very good work. And we are looking into you, and also you are looking into us. Thank you very much, and have a nice evening and very nice Christmas and the New Year, and have time to take care of ourselves a little bit more and enjoy in the family. Thanks to all. Fully, I would like to conclude maybe before we are starting to go out from the Zoom.
No, thank you. Thank you very much.
Thank you.
Okay, bye-bye.
Thank you.
See you next month.
Merry Christmas to everyone.
Bye.